Thank you. Lloyd Williams, London. Question for Dr. Muller-Wohlfahrt. The calf's liver extract that you inject, sir, you said it was a filtration or ultrafiltrate. How can you ensure that you do not risk disease transmission of prions, i.e. Creutzfeldt-Jakob disease, mad cow disease, from your calf extract? Has that been considered and dealt with?
Yeah, of course, these calves underlie control from the first day, and blood control, of course, and nutrition is to be controlled. So if you take the blood of these calves, you can look whether there's any bacteria or some infection. So I work 36 years, as I told, with this medicament. I never had a side effect, saw a side effect or complication. And I know from others, it's not known that there is intolerance against this. So I don't see any risk in using this.
Thank you.
Usama Janoun, sports and exercise medicine consultant in London. A question to Hans Müller-Wohlfahrt. The MRI imaging of the lumbar spine, I mean, you get a lot of patients who have no symptoms, who have positive MRI findings. In the players with spinal neuromuscular disorders, do you get the same results with treating patients with spinal interventions with those that have negative MRI findings as compared to positive MRI findings?
So my experience is that a lot of players have a neuromuscular problem. Maybe it's a high percentage in any case, non-structural injury. And as I told, the patients sometimes don't know that they have a problem in the spine, and they don't have in any case a degenerative process of the bulging disc. Sometimes it's only functional. Even SIG can cause muscle dysfunction, rising in the muscle tone. And if you train, you can train half an hour, it's okay, but after half an hour, the muscle tone rises more, and then the player gets anxious and feels that he can't go on, otherwise he will get a tear. So very often we see only functional reasons for the muscle problem.
Thank you. Another question there, yes. Again, a question to Müller-Wohlfahrt. I want to ask, when do you inject Actovigin the first time intramuscularly into the muscle?
Thank you for the question. If the injury happens in the first half time, I don't wait till the end of the game. I go immediate with the player into the cabin, in the locker room, and before he can have a shower or rest, I treat him immediate to prohibit a rising tone. The reaction of a muscle is normally to get compact, to protect the injury by contraction. And this means the blood circulation is worse, it's not even good anymore, and the metabolism is disturbed. So I win time and do this treatment as soon as possible.
With what?
with actovigine and traumel, and then we can watch that the tone stays low and the blood circulation and the metabolism is optimal. And after 2 days I repeat, and after more 2 days I repeat a second time, and then we keep the muscle down, and the healing process is accelerated by this way.
And directly into the place of the injury.
Yes, I have to, as I told you, we have to detect by fingers, by palpation. I can't wait for the next MRI or sonography. I'm in the stadium. I have to detect immediate, where is the center, where is the gap, and then 2 needles proximal, 2 needles distal, and 1 in the midst of the injury to get optimum conditions.
Thank you.
Nick Mafuli at the entrance. Professor Mafuli wants the microphone. Just at the entrance, there. The big man.
Oh, yep.
Great interest, eh?
Thank you. Well, I am standing, by the way, okay? This is not a question, it's much more of a remark. It is evident that in terms of muscle injury classifications, we have a situation of parallel evolution. It is also evident that the group that has worked in Munich was not aware that a group in London and in North America was working on another classification, which has been published a few weeks before the Munich classification in KESTA, in Knee Surgery, Sports Traumatology and Arthroscopy Journal. It is less articulated, possibly, and therefore simpler than the Munich classification, and we're going to present it today for the first time in international meeting at the ECOSET classification, at the ECOSET meeting this afternoon in one of the parallel sessions. So I prompt you all to come over and listen what we have to say about it. Thank you. If I'm involved, there's no competition.
Yes, good morning. Question to Müller-Wolfert. What you gave us as a new is a very outstanding information about the injection of actovigin that you said that in muscle tear give you directly muscle tissue instead of scar. And that's something that it's outstanding for us because it's I think it has to be proved histologically, because that means that when you put actovigin, you give a genetic information to the totipotent potential cells to become muscle directly and not scar. And that would be something incredibly new. Did you try with an investigation histologically on experimental studies on this?
I only can say I'm an empirical doctor. I have no possibility to do science. My day is 14 hours with Bayern Munich, with national team and many sportsmen, and with my patients in Munich. And so there's no chance for me to do science and to check it. Many years ago, I asked some authority in Germany, would it be possible to make Probeexcision, to take some muscle fibers? And then he said, no, you will not have a chance to publish this. It's unethic. So it's not me who could do it, but I would enjoy if somebody could do it for me. And what is, again, very important was a question about how clean is calf blood. There are, meanwhile, many editions, publications, which show that there never has been a complication. On actovigin, nobody can say there was a complication ever. Yeah.
Maybe I can add that there was a gene array made about 40,000 genes, and they saw in a mice model the NRI that there was a promotion of the muscle-specific genes after injection of actovegin. These are not our data, but these are data from the preliminary data from a lab.
Mm-hmm. Yes, we have a question there. A gentleman with the white shirt.
No. Thank you. No, it's rather dark.
Thank you. I have a question for Dr. Müller-Wolfert again. Excuse me for that. I don't understand what happened with Arjen Robben. Can you explain something about the mystery of Arjen Robben?
Robben. Played for Holland.
In his rehabilitation process, how could he play the World Cup with his hamstring injury? Can you tell us, or will tell us something about it?
This is a political question.
So, of course, I can't answer this question totally. But as you could see in the pictures, that was a test game in Amsterdam against Hungary. Brian injured quite bad. So my experience is a minor partial muscle tear leads to sharp pain, but you can walk. You will walk from the field and give sign, I can go on. Moderate partial tear, it always means the player falls down. So you saw he immediately fell down and gripped to his leg. That already was clear. This was a bad injury. And if we do a timing for this injury, then I say 6 weeks. This will last 6 weeks. That he could play in South Africa, I can't explain. I may not, and I can't explain. And when he came back from the World Cup, before he could train in Munich, I decided first I want to see him. I forbid him to train. First I want to check his muscle injury. And when he came, there was a big tear, big gap, some centimeters. And then I talked to the club and to the coach and to Arjen and family. I said, this will mean a long, long pause. And I recommended a pause about 4 months, maybe 5 months. So he came back in the back season. Not before. It was not possible. It was a hard job to get this muscle fixed. It was a bad tear. No, it was a big subtotal rupture. You could read in the newspaper, so I may say it here. Why he could play in South Africa is not. Don't want to talk about.
I can perhaps give a political comment on that. This example led to a great meeting within FIFA, where we brought together doctors of national teams and doctors of club teams just to try to avoid such situations in the future.
Last question here. No. Celeste. Okay, Celeste from New Zealand. I mean, she worked in Qatar, but she's from New Zealand.
Thank you. This is another question for Müller-Wolfert. You mentioned that you promote the use of ice compression and elevation immediately after the injury, and then before the end of the match you would inject the muscle with activagin to reduce the tone and increase the circulation. Can you elaborate a little bit more on the logic behind that?
The RICE principle means immediate compression and ice water treatment to prevent that the bleeding can go on. As I told, the bleeding leads to longer while for healing and regeneration. So we stop the bleeding immediate and keep down the inflammative reaction. That's the idea behind. And elevation is, that means the leg higher than the corpus, and to lower even the blood circulation in the leg. And what else you asked?
The micro is.
Is this question? So Actovigin I use because in the 60s it was invented in Munich. I knew of this, and I could read and I could hear that Actovigin improves the uptake of glucose into the muscle cell and the utilization. So you improve the metabolism and you give the cell more energy for healing.
Yes, I think. Yes.
That's one idea. And the other idea is, and that is proven, that the blood circulation is even accelerated or improved locally, only locally. And as we saw later, I did this for many, many years, only by empiric impressions. One German university phoned us and said, "You were right. We can see in the gene chip array that the muscle-specific genes are activated." So I did this treatment by experience, but now more and more scientists give me right in doing this therapy.
So thank you. We will stop here the discussion. We will make a break now. Thanks to the different speakers from this interesting session. Thanks for the audience.